We're obviously here today, and you're donning the blue scrubs at the moment.
Yep.
Looking mighty fine, may I add.
Thank you. These are clean, by the way. They haven't got any blood on them.
Are you sure?
Yeah, I'm sure. I did check.
All right. Thank you for that. I'll be doing a
Yep.
deep clean after this.
I would advise it. Yeah.
So one of the things that I wanted to talk to you about, or there's a bunch of things actually I wanted to talk to you about. But before we sort of like get into the things that we talked sort of off air, when we were talking about cochlear implants and tonsils and a bunch of other stuff, I just wanted to know, is being a doctor like what you thought it would be?
So yes and no. I, we can go pretty deep on this. I was fixated on the idea of being a doctor from about the age of 8. Like, was just dead keen always. And then when I was probably about 14 or so, starting to understand what the different types of medicine are, what different doctors do. Surgery was the one that really stood out. That was really cool. I think part of that was when I was young was probably the prestige behind it, really, which is, I think, not a good reason to do it, because they're all pretty. Firstly, that's not a great way, I think, to run your life, is just to go for the most prestigious role with the greatest clout behind it. But certainly, the more that I found out about surgery, the more and more I liked it, as I did about any type of medicine. And I loved, the more I understood about surgery, I love the concept where you've got a problem, you fix it, and you get to see the results with the patient the next day. Like, it's just so satisfying. It is, yeah, it's even better than I thought it would be, actually. It is very hard. I look back on it, and I've certainly had to sacrifice a lot in my 20s, more than I knew there'd be sacrifices. Everyone says there's going to be sacrifices. That's every single chat you get, every pep talk. The harsh consequences of those still, I can rationalize them. They're real. I totally understand, but still, the emotional impact of that's still pretty tough sometimes. But I'm pretty happy. I'm very happy with what I've done, and with how it is being a doctor. It's great. It's really, really sad. But you'd get similar things as well in physio, that, you take patients who are really debilitated, awful quality of life, and you help them heal and recover, and that's phenomenal. And there's probably a more close personal relationship that you get with physio than you might do with surgery. Like, we just see them, we see them more than once, but we'd only see them a couple of times.
You just see them just the once.
Yeah. Well, some surgeons do. Some surgeons will, particularly in the public system, when you only, where there's a team of surgeons operating, and you don't necessarily have the luxury of being able to see the patient. You should, but you don't have that luxury always in the public system, being able to see the patient prior to the operation and making choices regarding the management plan. You might be seeing them, the advanced surgeons might be seeing the patient for the first time on the day of surgery, and then might not see him again. And yeah, I don't like that aspect of it, but it still doesn't take away from the fact that it's a really, really satisfying job. It is very hard. It's a lot of work, but yeah, I've had no issues with lack of fulfillment. It's been great.
So 8 years old, you sort of were pretty fixated on doctor.
Yeah.
Teenager, started to develop more of an appreciation for surgery, and then like as you're going through, it's I speak to some people that sort of knew early age what they wanted to do. Probably in the minority, I would suspect. But like during the course of that, how many times did you feel that your faith in what you wanted to do wavered, if at all?
Never, actually. No, never wavered. I was not sure if I'd make it. I was, I always knew I wanted to be a doctor, and I think part of that too is that nothing else seemed to really to measure up to it. So up until I was, when I was in high school, I sort of looked at my role models, and I looked at my dad. He worked in a desk job. He didn't like it. He got a massive kick out of charity, was his big thing, and community involvement and coaching kids sport. Like, that was his sense of fulfillment. and
Shocking at that
yeah, yeah, exactly.
though.
Don't tell him that. Yeah, no,
Yeah,
no, he was good.
it was very good. Yeah.
Yeah, he's a good coach. And I guess taking a lead from that, I didn't really wasn't actively seeking out the desk job. Was actively trying to avoid it, and um, and because I was getting the marks at school, I kept at it. Got into medicine first year out, which was good, and was very happy when I was there. I didn't have any real doubts. The crisis was trying to get into surgery, and because once you become a doctor, you do your internship, and then you're a resident, and then the system at the moment is that you're an unaccredited registrar or a service registrar for a couple of years. For me, I stagnated a bit there. Was struggling to get in. It's pretty competitive to try and get in, and
Mm.
as it turns out, I ended up getting on at about the average time. But yeah, there was several years there as an unaccredited registrar. I had a couple of attempts to get on which failed, and it was I still had another two attempts left when I eventually got on, but I was
So you have a certain limit of the number of times
yeah
you can ask to
you
be
can apply
certified.
yeah, and you're applying to the Royal Australian College of Surgeons. Now, they've got a limit on the number of attempts, and I think that's a good thing because if you didn't, then like people are pretty determined to get onto surgery.
Mm.
It's a calling for it's supposed to be a calling for people, and if you didn't do that, then well, it's only they've only brought that into play recently, but there are people who'd be trying to get on 6, 7, 8 years, and some people just aren't going to get on, and it's a very hard pill to swallow to get to that point. But I was at that stage where I was if I don't get on this year, I really need to start looking at other options.
Yeah.
And I'd looked at, I still was refusing to give up surgery, and I'd looked at plastic surgery as a potential option as well. I interviewed for I'd interviewed for ENT before. I was interviewing for ENT again. I actually got an interview for plastic surgery as well. Got nowhere near as far, but yeah, that was the potential backup. But like that's not a good backup. It's a very competitive surgical specialty as well.
So you're working. So you start off as an intern,
Yeah.
and you're basically just rotating around different arenas
Mm.
within hospital
Mm-hmm.
settings for the most part
Mm.
to get a basic, broad understanding of everything that goes on.
Mm. Mm.
Then
Mm.
when you get promoted to resident,
Mm-hmm.
you're still sort of doing the same thing. You're still rotating
It's pretty
around a
similar.
bit.
Yeah, yeah.
Yeah.
The role doesn't change too much. People are really the internship, and this is Australia. This is pretty unique to. It's not unique to Australia. They've got this in Australia. They've got this in the UK. Very different to other parts of the world. So,
Mm.
say somewhere like the US, you start to stream down a particular specialty very early on. They've got a system called matching, where you match for a particular college. Um, they don't have that in Australia. It's an application process, and the pros is that there's probably greater flexibility and ability to change your career trajectory as a junior doctor before you've made up your mind. The con, though, is that the negative to that is that it takes quite a few more years to try and get into that specialty
Mm.
pathway, particularly for the for the more competitive ones. And so we get to a stage where we, we've got people who are trying to get onto a surgical specialty, and they might have been a doctor for 6, 7, 8 years at that point before they eventually settle on a particular specialty. Whereas if you were to go down one of the less competitive specialties, which are um, which are still incredibly important, you can get on much faster and have finished all your training and study by the time you finally get onto surgery.
So you're basically you're a resident for how long roughly before you're
I was
looking
a
for
resident for 2 years.
2 years?
Yep.
Okay. Then once you finish being a resident, you're then
Mm.
a registrar but
Mm.
uncertified. Is that what you're
Mm-hmm.
saying?
Yeah, yeah, yeah.
So then,
It's a service registrar or unaccredited registrar.
which basically means that you can practice medicine as a sole doctor, or
Sort of. So you're practicing, you're still in the public system.
Mhm.
Well, you can go private, but the main distinction in that role is that number one, you're not operating independently. You're always, um, and more importantly, you're not recognised by the College of Surgeons as a trainee surgeon, and you don't get the same teaching or development. You won't be recognised or be able to certified as a surgeon. Really, that role exists from a personal point of view to facilitate you getting into a training college,
Right.
but from a wider societal point of view, there's a pretty important role that they serve. There's a lot of outpatient work, clinic work, admin work, which needs to be done in the public system for surgery to work, and that's an increasingly important role. And probably one of the criticisms um, of the way surgery is conducted in public is there's too much of a reliance at the moment on unaccredited registrars. But it's just the way the system is developing. There's a lot of work that needs to be done, and not enough surgeons. And it's the sort of work which you probably don't want surgeons who are really
Mm.
expensive, highly specialized doing anyway. You want them operating and doing the difficult cases. You probably don't want them filling out paperwork behind the scenes.
So roughly, how long can people be uncertified for the register? Like, so you can apply for multiple years,
Mm.
trying to get into specialty, and that whole period you're just classified as sort of a.
There's no limit at the moment. You can the limit is how many application attempts you get. So we've
Mhm.
got. Well, I know service registrars who've been going for. I know one who's been going for a decade. He's used up his attempts and is now going for a less competitive one, but using the like he's still got a lot of skills and he's a very
Mhm.
intelligent person. He's going to go do radiology and he's really good at it. So yeah.
What do you think separates? I mean, do you have a sense now what separates people that get accepted into? I mean, you've now been accepted into the surgical ENT side of things.
Mm.
Do you have a sense of what separates people that get accepted and what people don't?
Everyone's got an opinion on this. I don't think there is a clear cut answer, and I think it's highly discretionary. Um, one of the yeah, a lot of ways to answer this. One of the things I think which separates people early, confidence is big.
Mm.
Um, the classic answer that, and it's this is an oversimplification, but uh, but the classic answer is that applicants who are successful need to be um, available. They need to be make themselves completely ready and completely commit themselves to surgery and just absolutely throw everything at it. They need to be affable. They need to be easy to get along with, and they need to be able. They need to be competent. Now, when you simplify it, and again, oversimplification, that's ultimately what it comes down to. The challenge, though, beyond that, is that almost every person who's applying is already available, affable, and able.
Mm.
You still are looking for things to try and differentiate yourselves. You need to differentiate yourself. You need to make sure that I guess nothing goes wrong, or there's no reason why people would have any second thoughts about you getting on. Um, you need to be at the top of your cohort. So there were two spots available for ENT in WA, and we had I think 14 applicants trying to go for it. And these are
Mm.
people who've been building up their CVs for years to try
Yeah.
and get on. It's a really hard system, but I'd love to say it was because I was available, affable, and able, but I think many of those other applicants were exceptional as well. I just had been working very hard to try and differentiate myself for a lot of years. Worked really hard at that application.
A little bit more affable then.
yeah, yeah, yeah.
Maybe just a fraction.
Maybe no,
Nah.
they're good people, and a lot of the people who didn't get on are still very good people as well.
So, you've been going through this process. You've gone from the student, intern, resident, registrar. Now that you're a trainee, sort of ENT surgeon. What's
Mm.
your current title, by the way?
Oh, training.
Still trainee. So, like going through this process, you already mentioned beforehand that the interaction with a patient, where you problem solve and the quality of life dramatically changes, is the most exciting part about it, and more so than you would have thought.
Mm-hmm.
Do you have a Doctor House moment that sort of sticks out in your mind?
Oh, okay. Couple of things to that. Firstly, Doctor House is rubbish. I wish it was good. It's rubbish. So this was heartbreaking for me because I looked at Doctor House as like almost like a role model when I was young, and we'd like make a big thing Sunday nights. Doctor House MD on Channel 10. That was like something our family sat down and watched together.
Yeah, yeah.
But it is a crap TV show from a medical standpoint. Like I remember there was one episode I rewatched it recently. I was like, "What the hell is this? What is he doing?" Um, there was a patient who came in. They were 13 years old, had abdominal pain, and they were really sick and unwell. And like there's a couple of differentials you think of. If they're young and female, you're thinking of appendicitis. You always want to rule out pregnancy, though, no matter what. That's just drummed into you. But on Doctor House, they didn't think about pregnancy. The patient got sicker and sicker. They did no tests, nothing, and it was a week down the line where they realized the patient had an ectopic pregnancy, and that was like, oh my gosh, it's 13. That was the whole thing about it. But that's like really basic medical.
Yeah, yeah,
It's
yeah.
bad. You know what is accurate is Scrubs.
Okay.
The TV show honestly
Yeah.
would that is Scrubs is brilliant, and
One of
there
my
are
favorites.
yeah, and there's so many key lessons out of it. Like it's funny and there's lots of jokes like there is in Hospital.
Mm,
There's also a lot of really beautiful sentimental moments that come
yeah.
out of it as well, like there are in Hospitals. Like Scrubs is pretty spot on. It's a little bit goofy, like there's not this yeah, but yeah, it's not far off.
I mean, you need that goof in there, otherwise.
Yeah.
The
There's a few good Doctor House moments, but yeah, I don't know. Like the the yeah, I can go into the weird cracking diagnoses, but
something for you that just stood out, something that's like was a really satisfying, I guess, solve for you or whatever it was that to you felt like, yeah, that's sort of a moment. I'm sure there's a few that pop around.
the big one that still sticks. There's lots. There's lots. The one which is easy to explain was there was a great moment which I still look back on fondly, where there was a kid who swallowed like a plastic Monopoly coin. This wasn't a diagnostic issue. This was like a treatment issue.
Monopoly coin.
Not just Monopoly coin, like a Connect Four,
Okay, sure. Yep,
like a
yep, yep,
Connect
yep.
Four coin. Kid swallowed it, got stuck, and it was like basically occluding their airway. And they got rushed in by the ambulance, and and the kid's tiring. They're starting to become a bit hypoxic, and like people are panicking. How the hell are we going to put this patient to sleep without blocking off the airway entirely? Um, and what do we do? Mum's like in tears, holding the kid, and they get brought into the kids' hospital, and there's about 30 people, like not everyone needed to be there. Some people are just like watching because it's just entertainment factor, I guess. I don't know,
Mm.
but people are trying to be helpful. But then, yeah, we were able to pretty much strap the kid down. Mum was holding the kid as well to keep them still. They were actually starting to they weren't fighting anymore. They were pretty lethargic and hypoxic. And we got we're able to just doing a couple of little maneuvers, extending out the neck and able to reposition them so that we had a good view. And actually, with my head torch and a few other things, was able to actually see the coin and just pull it out of the airway whilst the kid was awake in ED. And it was a real like, all of a sudden the kid took a big breath, like, and then just color very quickly came back to their face, and and the oxygen was on them, and mum's crying, one of the nurses is crying, and it was a very it's a very cinematic moment. It
Yeah.
sticks out for me. I was like, wow.
I'm expecting. Is there a round of applause in the background?
Yeah,
Yeah,
it
I
was
think there might have been.
I just yeah, look, I would love to say that it wasn't actually that difficult, but it just looked really, really cool.
Mm.
And it was so satisfying because the mum was really happy. The kid was starting to really not do well. And we're able to make a difference real quickly. That was a really, really special moment for me.
You know how we were just speaking a little bit beforehand about having heart rate monitors on football players so you can see what they're like in front of goal.
Yeah, yeah,
Gee,
yeah.
I would love to have known your heart rate
I was
monitor at
actually
that
pretty good.
point.
So
Pretty good?
yeah, the adrenaline helps. I, I've got a theory that
Okay.
there's two.
Hit me.
This is crap, by the way. This is not a proper medical theory.
No, it's
But
a proper medical theory by Dr. William Crohan coming up.
So there's different types of adrenaline. There's noradrenaline and adrenaline, and they tend to sort of release in different quantities in different situations. And I guess your body also responds differently to different situations. Then there's also another stress hormone, cortisol, which I think there's lots of stress hormones, but yeah, there's another stress hormone which gets released in chronic stressful situations. I have a feeling that noradrenaline, cortisol, I feel awful, rubbish, tense, uptight, and not happy with it. If there's a proper emergency, proper airway emergency, or patients dying in front of me, it becomes like a life or death. Like the adrenaline surge hits you, and it's so calming, and I love it.
Mm.
There's a moment there when the stakes are really high. I get a little bit like socially anxious sometimes. Probably my big area that I get, like I can make a speech, but like if it's a really tense meeting, for instance,
Mm-hmm.
or there's an argument, personal conflict, tense up a bit. I hate it. Hate
Mm.
that feeling. If it's a life or death emergency, the adrenaline will hit, all societal expectations, social pressures don't no longer matter. It's like it's my own personal thing. That's an issue I got, but when those concerns evaporate and you're just left with life or death scenario, you got to act and think clearly. Um, I like that feeling. It's almost like, yeah, it's like I've heard James Hurd described it. Um, this is footy analogies always come into it, hey.
Yeah, go for
But yeah, he's
it.
described it as being in the zone, and reading his biography and talking about how he talked about being in the zone on the footy field when he was really playing well. That was probably the thing which has best described it. When the adrenaline hits, you're in the zone, and I don't get nervous. I'll collapse in a heap afterwards. After
Mhm.
the event has taken place, then I'll be just exhausted. But at that moment in time, yeah, I don't get nervous, which is nice.
Even on the very first major incident or event, do you recall the very first, like, oh, this is like a real thing that I'm involved in?
Yeah, even in the first one was probably CPR.
Yeah.
Doing my first time doing CPR and trying to coordinate a patient's resuscitation. Yep, nerves evaporated. Just go into you just hit yeah you go into the zone and just do it.
Do you find that with, again, the bulk of the doctors around you, do you find that they get into the same state? Is
Some
it
do,
different for everyone?
some don't. And I think it
Yeah.
is one of the reasons, or one thing that maybe determines what pathway you go down. Not everyone feels as just. I've heard quite a few doctors describe that, but not everyone describes that. Some people don't want to be in those emergency scenarios at all, um, and they probably would, and they'd be seeking to avoid those critical care scenarios, and that's totally fine. Um, I'm, yeah, there's other specialties which don't have those critical care situations, but they have other really strong, demanding requirements, which I couldn't live up to. So yeah, it's different strokes for different folks.
It already sounds like an interesting litmus test for the trainee avenue of just like, all right, this situation, how does your adrenaline, noradrenaline, like, how do you
Yeah,
react in that
yeah, yeah,
situation?
100%. That's probably fair. That's probably fair.
Looking back again at the journey that you've taken, for anyone that's thinking about getting into medicine, do you sort of recall during your studies in particular, like, this actually really didn't matter that much at the end of it all, or that this area here probably needed a little bit more educational work on? Because from a physio point of view, we get a good understanding of anatomy, and I think hyper valuable and probably a little bit underappreciated. We
Mm.
do that sort of
Mm-hmm.
in the
Mm-hmm.
early on, and then there are some phases that you go through, which for a lot of physios that end up in the private world,
Mm.
it's not as sort of useful,
Mm.
but
Mm.
still
Mm.
can be helpful just again to try and get a better picture of the system at whole. But then there are just things that we just never were made aware of,
Yeah.
whether that be treatment styles, just general philosophies around health. There are just a bunch of things now that I incorporate into my own practice, which really didn't seem to pop up during sort of the study and becoming the professional itself. Was there anything like that within medicine,
Yeah.
or how do you feel the course is actually taught at
Yeah.
the end?
Fair bit. Look, the medical education has been a real hot topic in WA for a
Mm,
while, and there's been a lot of changes that have been made, and there's been a new medical school which opened up in Curtin, which was a real political hot potato for a while. And it was the fact that it opened up the fact that medical school was opened up in um, a swing electorate might have had a say in that as well. In saying that, the graduates that are coming out of it as they come into the hospitals all seem to be really good. Um, but the going to your question, yeah, there's lots of things which I think I've spent a lot of time learning about, which are not as practical. And there's a lot of things which I probably underappreciated at the time. The classic one was in our second year at uni. I was part of the old 6 year degree. Like it was the tried and tested one that UWA had been putting out for many years, which was very successful, and they started to fiddle with it afterwards. But the first 3 years were all preclinical, and then the last 3 years were all clinical. And in the second year, which is like the meat of a lot of the anatomy, physiology, um, they threw in there was a unit called Foundations of Clinical Practice, which was easily everyone's least, oh, I say least favorite. It was very chill, and no one took it seriously.
Right.
And it was all just about like the ethics of being a doctor and a lot of very wishy-washy stuff. So we go into anatomy, like this is, you know, these are the cranial nerves. This is the vasculature of the head and neck. This is the celiac plexus. These are the arteries coming off the aorta. Like very black and white, and this is what you need to know. It was very easy to grasp. But these are important things to understand. Whereas um, foundations of clinical practice. So, do you understand why a person from this background might react this way to this type of news or breaking bad news, or how this person might react this way? And how does that make you feel, and how do you think your reactions are affecting your ability to be a doctor? Which, without any clinical experience, we totally tuned out of.
Mm.
But as time's gone on, everyone I've talked to as well, and I feel that God probably didn't appreciate the importance of that. Like
Mm.
that's the soft skills of being a doctor, which are essential. Um, yeah, there was a lot on anatomy and on physiology, particularly physiology, to be honest, that I'll never use again. But there was a lot in foundations to clinical practice, which was gold, and we just didn't know it at the time.
Yeah. I
But yeah,
think I think you can't as well. It's definitely the same within physio. You really don't appreciate what you're learning until
mm,
in practice
mm,
when you're actually meeting and dealing with people.
yeah,
But then all of a sudden, the true meaning and value actually presents itself. You're like,
100%,
oh, that's right. It's no longer in the abstract where
yeah,
it's just that. It's just
uh,
abstract.
yeah,
As soon as it's brought into the real world, not only is it easier to pick up, but then your brain wants to understand and appreciate more as well. So
yeah,
it's a
yeah,
nice little, yeah, I'm sure that happen. It's got to happen. Everyone that I've ever spoken to that's completed a degree, there is a huge chunk of it that is
yeah,
practically useless to them
yeah,
now,
yeah,
because
yeah,
whatever they go into is now they're learning kind of
yeah,
on the job, and the
yeah.
bits that were important is
The
you
old
know, if it's to
criticism,
that point.
the old criticism of UWA's degree was that there was too much of that of the junk, but it was just like it just was giving you really solid backing, and it was a. I think you just never know what's going to be useful and what's not, which is tough. But there's like the Krebs cycle is a classic one that everyone learns about,
Yeah,
which is you spend yeah, exactly.
yeah,
You would have spent years learning it, but now actually, oh no, there's certain like mitochondrial DNA as it's becoming more researched, and we're understanding the genetic defects behind it. All of a sudden, the Krebs cycle is making a comeback. Like you just never know.
little storage at the back of the mind, like, oh, that's right.
Oh
Yeah,
God,
okay,
yeah, yeah. I mean, I
recognize what's
forgot.
going on there.
Yeah, exactly. That's a thing.
So you've now, and congrats by the way, you're now a trainee in ENT,
Yes,
ear
thank you.
nose throat.
Hmm.
Couple questions around that. First off, why ENT?
Well, I said that I focused on on medicine and surgery from a very young age. I kind of fell into ENT. Like I sort of knew I liked surgery. I was trying all the different ones. I thought I was going to be an orthopod going through med school before I even started doing any clinical practice. Like orthopods do sports, and they're all really blokey blokes and stuff. And oh yeah, okay, that's probably going to end up being me. But no, you get into it and like, oh, probably not quite what I had envisaged. Um, ENT has it's not certainly not one of the more glorified surgical specialties, and I think they like it that way.
Mm.
Um, it's snot, wax, and mucus. Like it can be quite gross, and it's also not shown in the on the TV shows very much at all, and probably for good reason. Like ENT is quite, I think more so than other surgical specialties, people will faint because it is quite graphic. Um, when doing the head and neck cancer role,
Think
yeah,
about
it is face off stuff. They are very complex surgeries. The anatomy is fantastic. The anatomy is amazing, but then you're really having to get in order to get cancers out from very difficult to reach spots. You're opening up people's faces or opening up their necks, and it is not one that gets glorified, but it is a really phenomenal specialty. Um, but ENT, I did that I got first exposed to it in my second last year, and I did a lot of work with Indigenous kids and learnt about um, chronic suppurative otitis media with fusion, and just disparate and the really poor health outcomes affecting Indigenous Australians, particularly in remote areas. That
mm.
was my exposure there, my first insight, and then went down that pathway because I was interested in that. And then, God, there's so much more to ENT as well. I did 6 weeks at the state. at Fiona Stanley Hospital, which has most of the head and neck cancer for the state. They do have a good centre as well at Charlie's, but just um, by demographics, most of them end up funneling into Fiona Stanley,
Mhm.
and that was just amazing. Huge surgery, really hectic stuff. Patients are very sick afterwards. I'm checking my phone every 30 seconds because I'm looking after patients on the ward at the moment, just recovering from surgery. But that was
So the
phenomenal.
scrubs aren't fake, actual real doctor then.
I did actually change the scrubs, I promise. um, but yeah, no, that's really cool. And then the more you learn about, again, I didn't think that I hadn't ruled out the specialties. I still was getting seeking and looking at everything. I nearly got into gen surg at one point. I had some really good mentors who were general surgeons, who were instrumental for me.
So you were applying into multiple
No,
different surgical areas.
I got experience in multiple areas.
Okay.
Did got into did a bit of general surgery. I had brief exposure to urology, but not enough. And but I had a pretty good exposure to general surgery, pretty good exposure to cardiothoracics. That's very cool surgery as well. But no, ENT was and plastics. I had a lot of exposure to. I like plastics a lot, and there's good people there. But no, ENT was the one that I had the most exposure to. And the more I saw of it, the more I loved. You've got incredible, hectic, amazing surgery with head and neck cancer, but you've also got smaller surgeries on kids, the tonsils, adenoids, and grommets, and they just make a tremendous difference to kids' lives. And um, last time I cried in a hospital was after a list for putting in kids' grommets to easy surgery, and I can go down that pathway. It's a good story, but
Yeah.
the comments of that in a second. But you can do that. You can do sinus operations. You can even do cosmetic surgery. You can do rhinoplasties, nose jobs, and they're actually very impressive surgeries as well. They're not to be scoffed at. They're pretty hard to do and very hard to do well.
You're leaving me hanging with the story.
Yeah. Okay. Well. Okay. All right.
All right.
Oh, it's just twist
And,
my arm.
yeah,
Twist my arm. So we did a remote trip up north, and there's outreach clinics and outreach trips where we do surgery in remote areas. So we were in Derby, and we went up. These kids had been waiting for too long for surgery. Basically, they get referred late, they present late, they spend a little bit of time on the wait list. So they probably all should have had surgery, a year or two prior. And there are these sort of 4 and 5 year olds who've got glue ear. They get this from eustachian tube dysfunction, which affects kids and particularly Indigenous kids for a multitude of reasons.
in simple terms, what does that all mean?
Fluid behind the eardrum,
Okay.
and it's because the fluid's not draining well, and it causes hearing loss.
Yep.
And it's a pretty critical age for it would be affecting these kids from 18 months onwards, and they got poor hearing. Pretty critical age for language development.
Mm.
Pretty critical age for social skill development and for the start of their early education. You need to be able to hear, and these kids, a lot of them, were really struggling to hear. They've got systems in place to try and compensate. Kids up north, some of these remote communities, the kids they'll have microphones and speakers in the rooms as the teachers are teaching, so that kids can actually hear what's going on. But we met the kids at the start of the day, and they're all quite deaf. Like, you're trying to chat to them, it's tricky. They can't quite understand you, and there's a little bit of there's a cultural barrier there as well, which we're working hard to overcome. Beautiful kids, parents were lovely, but um, yeah, they're very shy and withdrawn, and you have to repeat yourself a couple of times. And there were 6 of them. We just had booked for grommets, and they all had just a whole bunch of crud behind their eardrums, all this build up of secretions which wasn't draining.
That's what you mean by grommets, or you just mean young kids when you say grommets?
Oh, so grommets being a tube.
Yeah.
Sorry. So to treat it, because as kids grow up, their ears will become more mature. They will be able to deal with the secretion buildup. And so to just tie them over and to give them a better degree of hearing function whilst they're growing up, we put in a grommet in their ear. And a grommet is a tiny little piece of plastic. It's a plastic tube, sits in the eardrum, and it allows for ventilation of their ear, of their middle ear.
Right.
If there's air on either side of the eardrum, it can now move back and forward, and they can actually hear. And you get a fairly substantial improvement just by that small intervention. The surgery itself takes 5 minutes. It's quite low risk. It's very well tolerated. There are risks and complications with any procedure that we do, but this is a pretty
Yep.
benign operation as far as they go. There's a little bit of a learning curve. It's not like any Tom, Dick, and Harry off the streets could perform it, but
Certainly not this Harry.
it's an, but it's like it's a simple operation to do.
Right.
And then kids woke up, we sent them to the ward, and we did our post-op round at the end of the day, and the kids were just amazing. These kids, they're older than they should be normally. So we'd be doing these operations on sort of 2 and 3, even some 4-year-olds down in Perth. These kids were 4, 5, 6. They had enough insight to realize to realize that something had changed, and they were very cognizant of the fact that they could suddenly hear,
Mm.
and they would not shut up. They were going nuts on the ward. Whilst before I was struggling to talk to them, they'd be going, oh, "Hey, Mister, what was your name?" And they were wanting to play, and they were wanting to talk to everyone and everything. They were so excited, and they knew that something had happened to their ears, and they could suddenly hear. And they were thankful, but they were just the main thing about it was they were just so excited to be able to hear, and that was like. I was pretty emotional. It was a really nice because they're all sitting in the same room as well, and everyone's like quite quiet and a bit withdrawn at the start of the day. And at the end of the day, parents are like, "What the hell's going on?" The kids are running around, absolute chaos. It's beautiful. It was so nice. I had I got a bit emotional. It was just because a very routine operation, and you probably don't always appreciate the impact it can make to someone's life. But it was pretty good for that at that moment.
Very cool. So restoring a bit of hearing. The other two areas that I'm coming to mind when I hear ENT would be smell and
Yeah,
taste.
yeah.
Is there things that you do that restore those
Not
two
so much.
components, or it's not quite
So
the same?
they're linked, and we know
Mm.
that if you've got poor sense of smell, and then your sense of taste will be compromised as well. Probably for that, not quite as life changing,
Yeah,
but
sure.
people do really people,
To be fair, it would actually be amazing if you didn't have smell and you could smell
people
again.
care about it,
Yeah,
and
your senses are
yeah,
insane.
exactly. People care about it a lot, and people also care a lot about being able to breathe properly. And
Mm.
as you would, and it makes a massive difference to your general quality of life, your functioning in day to day life, your quality of sleep. Yeah, we do operations inside the nose and at the back of the throat all the time to improve people's ability to breathe and for their day to day function. And that's really satisfying too. Like more so because it swells up a lot post operatively. They'll wake up still with a blocked nose. It doesn't feel like you've changed anything. But then 6 weeks down the line, there's generally a lot of. They come in and they're pretty happy. They're pretty happy. They're happy to see you. They're happy that
Mm.
they're suddenly able to breathe and they're able to sleep properly. That's a really nice moment. There's lots of things we can do inside the nose and at the back of the throat to improve your ability to breathe, but that also is a very satisfying moment.
I do have a question as well about the ears and the blockages. It's just
Yes,
we've
gone.
gone over it. Should we be removing excess wax in the ears or getting clean outs?
So the official line from ENT, we don't want um, we don't want you to be using cotton buds to clean out the ear.
Mm-hmm.
They've actually, cotton buds, they'll clean out a bit of wax, they'll push more in. Keep doing it, it'll lead to wax impaction. Um, the best way to clean out your ears is to use dissolving drops. So Waxol's the classic one. You get it over the counter at the chemist. It actually is mainly just olive oil. So just using some olive oil will help um, to dissolve the wax a bit, and then you can use like a bit of tissue or you roll up the bit of tissue into something called a tissue spear, and you can use that to just absorb the moisture. You do that with enough time, and your body is naturally trying to clear the wax anyway. So that shouldn't be something that's so bad that you need to use cotton buds. We don't like syringing either. We often see that syringing the ears with water leaves water in there and can lead to secondary infection. Um, just having wax in the ears itself is also not a bad thing. Wax is like being made by the body for a reason.
Mm.
Wax is slightly acidic and it's oil based, so it's hydrophobic by definition. We know that bugs love these. I say bugs, not insects, but like bacteria fungus. These things love moist, dark environments. They don't like acidity. So wax is naturally protecting the body against infection a bit. Now, if you get a build-up of wax, it's uncomfortable, but you can just use wax dissolving drops to try and get rid of that.
So you're not usually looking to do like a yearly clean out. There's no sort of like the dentist telling you, make sure you floss every day. There's no like generalized cleaning that's
No,
recommended at
you
the
shouldn't.
years.
You shouldn't need to. Some people still do. Some people might have very hairy ear canals or narrow ear canals. They might need a little bit of extra help. And yeah, like particularly in the private sector, they're very happy to facilitate that. It's a
Yeah.
very safe way of doing it. But whereas the wax dissolving drops take a bit of extra effort. But yeah, you don't. No one should need to have the wax being cleared out regularly unless there is something else going on with the ears.
Okay. So no maintenance necessarily required. This is going to be.
I should also put a
Mhm.
caveat on that because it's particularly in WA and all these water loving parts of the world. One of the really common complications we see is that if you've got consistent and repeated exposure to cold water in the ears, you can actually have you'll have periostitis and irritation of the bone, which then builds up and leads to extra layers of bone being developed in the ear, which leads to excessively narrow ear canals. That can cause you issues.
Right.
So sometimes we see the blocked ears build up a wax. Um, that's actually due to ear canal exostoses, and that's something that we can look at potentially trying to resolve as well. That's a surgical issue, unfortunately.
Is that something though that you're not getting until 10, 20, 30 years down the line when you've been exposed to cold water all the time and you get these ear aches after you've
Mm.
gone for a swim?
It's not something you'll get in like a 12-year-old, but no, it's not uncommon in the 20, 30-year-olds. It's definitely common actually. I've got a few mates who, with lots of exposure to cold water, have developed these bony canal exostoses. Tricky operation, and like they do recur. So if you can avoid or manage it conservatively, avoid surgery, then that's ideal. But some people still need to have it operated on. It's a real it's a classic one which just affects like the really fit people. So we'll get like it's a funny one if you understand it. You'll get
The Iron Men and Iron Women sort of
yeah,
stuff.
and you get this clinic where like the little kids coming in, and then you got the older patients with a lot of comorbidities coming in for like head and neck cancer surgeries, and then some 6'5" bloke who's built like a
A brick poo house.
yeah exactly. So wouldn't I say that? Yeah,
Well, I'll say shit house, but you
yeah.
might prefer not.
They come in, so it's a nice variety if you get the ENT. Yeah.
Yeah, okay. Not too bad. And then so like ear wise, all right, that's a little bit of something to be aware of. Again, huge sweeping generalization, but just like the top couple things that come to mind in terms of what I should be looking for if I was to go, oh, maybe I've got something actually worth investigating when it comes to, nasal passage or throat, or what are the sort of things that I guess like as a person that might need your services at some point be looking out for?
There's a lot of different things which I think are underappreciated. With your hearing loss is a normal part of aging, but hearing loss in young people is not normal, and hearing loss in older people is worthwhile investigating and treating. Most of the time, that will be just with a set of hearing aids. That's fine. That's really, and I would encourage people to use hearing aids if they feel they need it. Um, there's actually some research. There's a really good study um, which has been released, I think, in 2021. And there was further work done by the World Health Organization way back from 2011 up to 2017, which now demonstrates a very strong link between hearing loss and dementia. And in
Hmm.
fact, hearing loss is um, the number one preventable cause of dementia worldwide. So that still leaves 2/3 of dementia we don't actually have a cure or prevention for. But just through loss of cognitive input, through social isolation that comes with it, we know that hearing loss can cause dementia. It's worthwhile treating, and hearing aids have now been demonstrated to be one effective measure for the prevention of dementia.
So is the onset,
That's one thing to watch out for. But yeah.
is there, with that alone, so with the onset of hearing loss, are there certain factors that predispose someone to an increase in hearing loss or an
Yeah.
earlier onset of it?
Yeah.
I'm guessing, genetics probably plays a part, maybe loud music, but yeah, what are the sort of things that you guys see?
Yeah, definitely. So like, there's many different causes for hearing loss, and I couldn't possibly list them all. But for our
Oh, come on,
general,
man.
it's now been it's now been well demonstrated that loud music and constant use of headphones in particular can cause hearing loss, and it's been shown that that's happening more and more at a younger age
Mm.
in younger generations because we're all using headphones all the time, myself included. Um, and headphones at a louder volume, and especially, can cause hearing loss. There's also, as you said, occupational exposure to loud noises constantly. There's a reason that people have to use um, hearing protection devices if they're on construction sites. There's
Mm.
good reasons for that. Certain medications can cause it, some more so than others. Chemotherapy is a classic one for causing hearing loss. But then even simple things, certain types of antibiotics, aspirin and Nurofen potentially can lead to hearing loss. So that'd be pretty unlucky. Um, there's lots of genetic causes, and then recurrent ear infections can potentially cause hearing loss as well. Yeah, there's I can go on. There's lots and lots of things to be mindful of, but protecting your hearing is very important.
So obviously protecting the hearing through physical barriers, if
Yeah,
you're on a work site and things, as you said, very important
yeah.
for protecting the hearing loss. Are there any things people can do in order to try and either recoup some of that hearing loss outside of age? You know, is there certain lifestyle things that seem to make a difference? Is it
That's the thing. There's not. There's
right?
not. That's the concerning thing. So if there's um unless there's different parts of your hearing. There's like the air conduction, and then there is the sensory and neural component of hearing. Air conduction is like from the eardrum, or it's actually from the ear itself, pinna. There's augmentation of hearing at that point, and then it gets amplified as it travels down it gets directed from the pinna, amplified in the ear canal, and the eardrum ossicles, the little bones of conduction, smallest bones in the body. Then it gets amplified by about 25-fold before it gets to the cochlea, and then the cochlea turns all those vibrations into um, electrochemical signals for the brain. We can fix and we can bypass a lot of those conductive parts of hearing. Very tricky to do in certain situations, but there are methods of doing so which are surgical. But once you lose your hearing in the cochlea, there's not really any coming back from that. And you need to be looking at things like a cochlear implant if you've really lost a lot of hearing there. You can augment it to an extent, but there comes a point where where hearing aids and hearing um, and conductive hearing devices are no longer effective, and yeah, cochlear implants the next step, and that's a big operation.
And can you describe in as simple terms as possible, like how does a cochlear implant actually then work?
Yeah, so cochlear implant. I've done a bit of research on this, as you know.
Mm-hmm.
Cochlear implant's an amazing piece of technology. It's basically it's a 2 centimeter little 2 centimeter little noodle, and it goes into the cochlea. The cochlea is a tiny structure. It's shaped like a rolled up sort of shell, cockle shell. It's sort of the way the Latin. It's a Latin for for shell. Um, and if you rolled it out flat, basically, one end of the cochlea responds to low frequency sounds, the other end responds to high frequency sounds, and we insert the electrode, the little plastic noodle, into that little channel. The hair cells, which normally are responsible for generating these electrochemical signals, they're often no longer functioning. But you've still got the cochlear nerve that's in that structure, which normally would be getting signals from the hair cells. Instead, we have of this on this electrode a number of different electrical centers, and they will zap the cochlear nerve to certain areas which correspond to certain frequencies. The end result, it's not as good as your normal hearing. So you've got 10,000 different frequencies, or a bit more than that when you're looking at normal hearing. And the cochlear electrode, it's 20 millimeters of what's it, 28 millimeter. 30, no, sorry, the new ones are 32 millimeters. I'm getting sidetracked.
Yeah,
Um,
in the weeds.
but you've only got between 8 and 16 different electrode ports that you can actually stimulate the nerve at, which correspond to, let's say, 16 different frequencies. So the end result ends up being a bit tinny and robotic. But in these patients who are completely deaf otherwise, it's phenomenal technology, and
Mm.
it gives people their lives back. Music perception of again, it's not good as normal hearing. So your music perception of sound in noisy environments and sound localization, not going to be quite as good. You need really nuanced hearing for that. You
Mm.
don't get that with the cochlear implant yet, but it is a phenomenal piece of technology. Um, and it is just improving at a rate of knots.
Mm.
Like they've got devices which can connect to your phones. You can play music through them.
Mm.
Um, the
Dad's got one of those.
yeah. It's just it gets better and better. It's crazy technology. It is there's a lot of research going into it, and I expect it's an area that will really improve in the futures and years to come.
So I wanted to talk a little bit about the research that you've done in that. But just back on the cochlea, so you're saying that there's roughly like eight varieties of signals or colors, as you might want to call them, or something like that, which
Yeah,
allows for a certain frequency or range of
yeah,
things to be
exactly.
heard,
Yeah,
as opposed to what would classically be like a 10,000.
yeah, exactly.
So, is there any reasons why we can't scale up this, from 8 eventually to 10,000? Does it just take time and technology?
It's just how yeah, it's just time and technology. So it's just how close those little electrodes are to the cochlear nerve itself, and how many you can actually fit on that small, tiny little bit of plastic. But you can appreciate that, and it's tricky as well because the electrode might not be sitting directly against the cochlear nerve. If you had that, then that might be able to get you some. It might be able to improve. Gets a bit more technical, but you could probably get better quality. You can get better quality sound perception, um, if that's achievable. Much easier said than done. Um, but if you were able to fit more electrodes onto an implant um, without compromising stimulation of the cochlear nerve
Mm.
at distinct frequencies, then that would be the next step. And definitely there's a lot of effort being made to improve cochlear implantation in that direction.
So, when you've in the past done a bunch of research specifically on cochlear implants, or I believe on the technique of implanting
Hmm
it in
hmm
order to reduce the range of sort of frequencies or air pressure variability, as
Yeah,
you.
exactly. Pressure very yeah, so we're trying to work out the impetus behind this is to expand the indications for cochlear implantation. We talked about deafness and how cochlear implantation can be really good for it. Very rarely are people completely deaf, um, and you might also be more deaf in certain frequencies than others. And the classic ones, almost everyone's like that. It's age-related hearing loss disproportionately affects the higher frequencies, because those frequencies are are closest to the base of the cochlea, which then get affected by changes in pressure. Um, uh, we know that if you put in a cochlear implant, at least historically, it has the potential to destroy all of someone's residual hearing. And so if you've got someone who's got, reasonable and functional hearing at the low frequencies, and you're putting in a cochlear implant, which isn't quite as good as normal hearing, it's very good, but it isn't quite as good as normal hearing, then actually you can lead to a worse outcome by destroying all of that person's residual hearing.
Mm.
However, in the 2000s, we started to realize that certain patients we could preserve their residual hearing and also um, complement their residual hearing with the artificial hearing of a cochlear implant. And they had magnificent outcomes, really good outcomes with respect to music perception, sound localization, conversation in noisy environments, and overall a much higher quality of life that these people were describing. We still just had no idea how to do it. We knew that if it went in a traumatic fashion, that if you were destroying really microscopic structures in the cochlea, then that was causing a drop in their residual hearing. But then there are all these patients who are being operated on where it was a technically perfect operation, didn't cause any histological damage, and yet they were still losing all their residual hearing. So we're trying to look for all these different causes, and one of the clear ones that came out, which my research has been focusing on, is drops in pressure. And like it's such a sensitive structure. You put in a cochlear implant, the pressure change inside the cochlea when you put in a cochlear implant, if you do it just in the traditional method, it's the pressure jump is what you would see in an explosion. They've studied this particularly with blast trauma in IED devices in the Gulf War and in war and military trauma like in Iraq,
Mm.
and looking at the effect of blast trauma in the ear. It's the same types of pressure changes that you get when you put in a cochlear implant. So it's very, very
Yeah,
loud
wow.
and it's enough to destroy all of someone's residual hearing. So we've been trying to look at ways to improve surgical technique to reduce the amount of pressure that you put that is reduce the pressure change inside the cochlea during implantation.
So the pressure comes from as you're putting in the instruments, like air that gets trapped behind, or the
Lots of
actual.
different changes. Lots of different changes. Even just like your innate, everyone's got a little tremor.
Mm.
Even just your innate tremor
Right.
is at about 120 decibels, and like a loud rock concert. So if we can take away all of the and you can't see your innate tremor. You can only see really under a microscope what your hand's actually doing. But yeah, that's enough to cause some sort of damage to the cochlea.
I can actually show you. Do you want to know how you can see your innate tremor?
Yeah.
I made a game of this a while
Yeah, here we
ago.
go. Give me a physio trick.
The game of this one is all you do is you get your index finger and your thumb. You can try this at home, everyone. Index finger and thumb. And then what you're trying to do is you're actually trying to get them as close as possible together without them touching. And what you'll notice is when you're trying to hold it as close as you can without them touching, there is a little tremor that you can actually visibly see.
There you go. Damn. I thought I had a pretty good. I thought I was pretty good for having no tremor. I've just had like 3 coffees, so
Yeah, that's true. That's true. Yeah, we did
um,
caffeine you up as well.
yeah. There you go. Exactly. So yeah, so that's enough. That'll cause a big change, and that's also one of the reasons why they're looking at more and more robotic, robotic surgery for cochlear implantation, and there's probably a real future there. Actually, that's really exciting.
Mm.
It's really exciting stuff.
All the nano stuff coming out.
Yeah,
Very
exactly.
cool. Well, because I wanted to ask you about you've done a TED talk on this as well, which is titled what is it? Something like "You are who you are, not who you're not."
Oh,
Or something.
that was about the TED talk was like
It was more about
like a
so the
crazy experience.
imposter syndrome sort of stuff.
Yeah, because like the research was gold. I probably didn't appreciate it at the time, but um, the I was presenting this research and I got like a really good spot in the cochlear implant symposium. Um, Really exciting, and but I was like, what the hell am I doing here? Because they had 2 multinational, huge companies which were presenting their recent updates, and I'm presenting like my little knick-knack operation, which was in the back sheds. Well, not back sheds, but just I was operating solo in Harry Perkin Institute, and uh, and I just didn't think it was that important. Certainly not important enough to warrant attention at the major cochlear implant symposium on the main floor, like the golden time to at 9 o'clock in the morning, the golden time to do it. I was presenting in front of 400 people, and I was like, this is a waste of everyone's time. What am I doing here? I can just give up my presentation, and the guy after me can speak for a bit longer. That might be nice because he had a really cool multi-million-dollar robot he was presenting to the world for the first time. But no, it was good. The reception was a lot better than I thought it was going to be, and certainly the findings of that research have been implemented in some of the newer robots coming out, which is really cool.
Because I believe, didn't you set up a little stall where people could test to see how much vertical pressure
Yeah, and
that went on when they would actually do the surgery?
exactly,
Itself?
and we measured this against how this is a paper I published recently. We're measuring as well this against how good how good a robot can do it. So we're comparing humans to robots basically,
Mm-hmm.
and even the best cochlear implant surgeon in the world, I say he was the best. He's generally regarded to be like top couple, and he also won that competition. So there's evidence there. His best insertion was about half as good, just purely looking at the pressure variability compared to a robotic insertion. A lot of caveats to that, and robotic surgery still has a long way to go. But yeah, there's a real future for robotic surgery and cochlear implantation.
I want to get back to the research, but just on that, if something was to go wrong in the robotic surgery, is the company that produced the robots liable?
That's a massive ethical question.
Yeah.
A lot of discussion on that. So no, is the answer to your question. There still has to be a surgeon in the room, or who's liable, who's controlling and in using the device and operating it. Now, if the robot's stuffing up, they've been really conservative with this. The cochlear implant company knows that all it takes is for one stuff up, for the surgeon to be unhappy with the results of the robot, and they're never going to use it again. Ethically, you couldn't use it again, and it's been a slow roll. They know they've got a good product. They know they've got a real game changer. Everyone does, but they're being very slow and deliberate in in rolling it out. They're not even giving it out to everyone. They're giving it out to surgeons that they know and trust, so that they can build up a whole body of research. They can get through. They've done hundreds now
Mm.
of these perfect robotic surgeries without any mistakes and complications. They know exactly the what the strengths and limitations of the robotic device are, and that's how they're slowly rolling it out. Because uh, yeah, the responsibility still falls upon the surgeon, but no surgeon is ever going to want to use a faulty robot for their operations.
Mm.
They have to have so much faith and trust in what they're
Mm.
doing. And
So no autonomous surgeries coming out anytime
no, we're
soon.
still a long way off that. Actually,
Yeah.
we're still a long way off. They've really found it difficult to bridge that gap. Um, there's different scales of robotic surgery, and yeah, we still haven't got to a stage with pretty much any operation where it's possible and also feasible to have a completely autonomous operation.
Yeah, okay.
Yeah, there's too much variability. Probably will happen at some point in the future, but um, even then, there still seems like there's a role for surgeons at some level. At least I can't. I can't. It's been around for a while now, robotic surgery, and we just haven't been able to bridge that gap yet.
So I'm a hobbyist when it comes to science, or maybe more the philosophy of science.
Yeah, cool.
But I myself haven't engaged in legitimate research within a university.
Yeah,
So I was curious to know, during the research phase, which I'm guessing you're still ongoing to some degree as well.
yeah. Still got
Like,
a PhD going. Yeah.
how do you actually find the world of research? Do you feel that in the world of research, good science is being done?
Mm-hmm.
And what are your thoughts, I guess, on the research side of the world?
Oh, I think it's great. Uh, I think that the world of research is as strong as it's ever been. There is always interesting. There's many different ways you can go down with this, but yeah, I think science itself is in a very good spot. That there is still enormous prestige being attached to good clinical research, and there's good leadership in the field as well. There are obviously caveats to that. There's a lot of research being conducted, and there's a spectrum of the quality of that. You go to the old school, high functioning and really prestigious medical papers. They're still just as good as ever. The New England Journal of Medicine's the BMJ JAMA the JAMA network. Even in Australia, the ANZ Journal of Surgery is still it's very hard to get research published on that unless you're able to just really meticulously demonstrate all of your logic, reasoning, and scientific method. Good quality research there. That said, there's a lot of junk. There's a lot
Mm.
of junk out there. Every day I'll get a message from the some dodgy journal from Whoop Whoop where they're trying where it's predatory. There's predatory scientific journalism going on.
Mm.
They'll offer, oh, we're looking to publish. Very happy for you to publish in our journal. There is a small publishing fee of $1,000. If you want to get your paper published, then let us know, and they'll just publish any sort of junk. But people like scientists, researchers will know that's crap.
Mm.
That's absolute crap. Don't trust anything you read in that. They're just making a buck. And yet, unfortunately, in the media, not people in the media might not realize that that's what the purpose of these journals are. And it's that. And then if something from one of those journals then gets attraction, gains a foothold in the media, in the news sphere, then that can cause some damage and harm. That's a concern. It's not
Mm.
harming the overall quality of research, and like the 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 progress of science is not everything gets analyzed and hyper-analyzed, and everyone's trying to sort of poke holes in the latest scientific theory. There's good scientific method taking place, but yeah, the challenge I think is when um, non-scientific media gets a hold of these things and tries to
Mm.
run with it. It's not good. And then the other issue as well, which it ties into it, is money makes the world go round. Money is funding a lot of these, but when you introduce financial incentives into good science, then that can muddy the waters as well. And there's so much being done to try and keep everything as transparent as possible. But it's still, I can see it at these conferences I go to. You can see that some of the really glitzy presentations with a lot of money behind them are trying really hard to convince people of these new types of
Mm.
theories. and there is a financial incentive
There's
behind it.
commercial
People are
supported behind
clued
it.
onto it. People are clued onto it. The head researchers, the head scientists from every institution are very aware of it. But it's a trap for young players, and it's a trap for people who aren't familiar with the system.
So then, when you're actually conducting the research yourself, what is the process of doing good science?
Yeah, so it's there's a lot to it, and there's lots of guidelines which help you follow good scientific method. But yeah, it has to be uh, easily demonstrable. You have to it has to be easily reproducible. If someone who wants to carry out that experiment and see it for themselves, you have to be able to outline in exact terms what you did so that they can reproduce it. There are a lot of biases and caveats and potential mistakes that can be made within science, and a lot of these are limitations that you can't really avoid, but you have to address them and acknowledge them.
Mm.
I got a paper actually literally rejected last night. I'm gonna have to try and rewrite it because I didn't go into enough detail of the limitations of this scientific study, and it's pretty good. The reasons were fine. Um, I can't change those limitations. The paper's already been conducted. It was a retrospective as opposed to a prospective study, which means it's already been the research has been carried out a couple of years ago.
Mhm.
I'm just trying to I'm just trying to present it, and I have to be honest. Like, oh, we couldn't really balance for these biases, and we couldn't. I can't tell you who was vaccinated and who was not, um, because we just don't have the data available anymore. Um, and that's fine as long as you acknowledge it and you're very very specific about it. But yeah, there's a sense of integrity that comes with good scientific research, acknowledging all potential sources of mistakes, biases, and producing it in such a way where it can be reproduced. Nowadays, as well, there's a really strong emphasis on making sure all of your data is publicly available, which is a little bit intimidating. You're just kind of throwing off all your hard work into the public um, into the public eye, and it can either be you're worried it can be twisted, or you're worried it can be manipulated, or that someone could just steal it and write a better paper, which they get credit for. But yeah, there's these obligations that you have to fulfill good scientific research, and that's part of it.
So when you're presenting or putting forth a bit of research, the initial question, the hypothesis that you're trying to, I'm guessing, more disprove than prove. I'm assuming is null hypothesis
Yeah, null hypothesis
pretty
still a
pretty
thing.
common.
Yeah, 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 yeah.
Uh, I only know about that not because again I'm a researcher, but I'm just a fan of Karl Popper, who put that forward as the right way to produce science for the most
Yeah,
part.
yeah.
Which is just saying like you're basically telling everyone not how can I prove this, but it's how can you disprove this
Mm-hmm.
because you're more likely, as the incentive structure would have you, you're more likely going to try and prove yourself correct.
Mm-hmm,
So
mm-hmm.
it's better to have the incentive to try and prove yourself wrong.
Yeah, that's a good way of putting it. Yeah, yeah.
Um, so when you're coming up with a question to begin with, is this your own question? Is this from a bunch of people? Like, how is the original, what I'm trying to now understand better, that
Mm,
very first, what are we trying to understand? Where does that come from?
mm. There's a um, look. It comes from a lot of preparation. You need to have a good understanding of what the literature says, what the current paradigm is within the literature, within the scientific body of knowledge. You need to know what the specific issue or question is that you have, and it's going to be with a particular type of population in a particular circumstance. You're looking for what the status quo is or what the control is, and you're looking for the outcome of this particular intervention. So that all needs to be really well defined. You're talking about the null hypothesis the hypothesis of your study needs to be outlined prior to you starting.
Mm.
And the aims of the trial need to be clearly stated as well. And this all needs to be put out um, in advance.
And are you, again, you can choose and sort of pick anything you like,
Yeah.
or is it a little bit sort of, there's already sort of options provided that you're picking from?
You can choose anything you like. Yeah, absolutely, you can choose anything you like. The importance of this, though, is that the quality of the research, as deemed by in the public eye, is going to be determined in part, by the preparation that you put in beforehand, and the way that you're able to explain your logic and reasoning for conducting this paper. This is actually again speaks to the increasing quality of research. That nowadays, particularly with randomized clinical trials, with prospective randomized clinical trials, like the highest level of evidence that we have, people will often register their clinical trials in advance. You can't be adjusting or trying to fiddle with the aims and
Mm.
the methods after the fact. You're actually publishing in advance what it is you intend to do, um, and you're registering the trial, but everyone can check up on it. And then when you present the research years later, it just gives another level of transparency. A lot of really good trials from really good centers are doing that.
So just to hinge back on what you said earlier as well, saying there's a bit of a push now for your data to be public after publishing or during publishing.
Mm-hmm.
Is
After,
that
yeah, yeah.
why do you think there's a push for that at the moment? Yeah.
There's always a temptation to people to fudge the numbers.
Okay.
There's like if you're, and this is where I think financial incentives come into play a little bit. If you've got a clear financial incentive to publish a clinical outcome that or a significant finding, and like it's much easier said than done to say, oh no, you never do that. But um, there's always the temptation. Maybe something went wrong with the trial. Maybe this one person just didn't follow or a couple of people didn't follow the trial regulations, and you had to exclude them. And you know that if they'd been included and they'd done what they were supposed to do, you would have had a significant outcome, or you think you know.
Mm.
Then yeah, there's always a temptation to um, to change their numbers to what you think might have actually been more correct, and trying to find an outcome. But you're still changing the quality of the science. You're still changing the outcomes, and potentially, uh, and you're ruining the quality of the scientific research.
I did hear a stat, and again, it's one of those social media stats, so take it with a grain of salt. Max Lugavere, I think, is the one that he talked about it. That there was a recent study that sort of suggested that somewhere in the order of like 90% of studies published had either poor data or poor like tinkering done within the data. At least this was
Yeah,
an American thing as well.
yeah.
So again, can't say that
Where'd they
with
get that
absolute
from?
certainty.
Yeah,
I
I'm still
mean,
skeptical of that number two. But I would. The
yeah.
temptation's there though. I certainly appreciate it, and I also appreciate everything being done to keep science as transparent as possible and far away from the
Mm.
money as possible as well.
Plus, I suppose UWA is a publicly funded university. Is that
Yep.
right to say? So, by virtue, the research is therefore sort of paid for by taxpayers.
Mm-hmm. Mm-hmm.
Therefore, the information, or I guess everything being public, also I guess makes sense in the fact that it's meant to be like a public thing, right? Sort
Yeah.
of like a public good.
Mm-hmm. Mm-hmm.
Um, and interestingly enough, like within that sort of logic, journals have a paywall for the most part. Is that right as well? That they tend to have a paywall if you're
Yeah.
trying to
There's
access.
the paywalls are not a big barrier. If you're a member of an institution, generally you get automatic access to most journals. So,
Okay.
so yeah, paywalls are not ideal, and it's a barrier for average people to get into research,
Mm.
which is an issue. But yeah, there's ways around it.
So for instance, the research that you've published, or the papers that you've published so far or been a part of, are they public access? Are they behind paywalls?
Some of mine are behind paywalls, but the most recent ones I've done are actually open access.
What do you think that is?
Why do I think it's?
Why do paywalls get introduced into public science?
Oh, I think it's because it costs money to produce this type of to edit these journals.
Mm.
To you're still relying on a lot of goodwill. People who are doing the editing, who are reviewing these articles, generally are doing it for free. I've had to review articles. I'd say I've enjoyed reviewing articles in the past. But yeah, it still costs money to pay the admin staff to run the journal and to publish it regularly, and you got to get the money from somewhere.
Mm.
So you don't want to have lots of advertising in your scientific journal. That introduces another
Mm.
financial incentive, and these advertisers might have their own agendas. You want to try and keep it free of that, and else you wouldn't get that much money from scientific journals advertising away.
Now that I think about it, who owns the journals? Is it private groups or are they
It's
organizations?
So I think every journal has a different owner. They're not big multinational companies. They're not rich. The Royal Australian College of Surgeons, they have they're the ones who run the ANZ Journal of Surgery. I couldn't tell you off the top of my head who runs the the BMJ, but it's a big medical institute in the UK, which has a lot of public funding.
Mhm.
Most of the big journals are not. They're often run as not for profits.
Okay.
I couldn't tell you off the top of my head. I don't know the source of the,
So
but yeah.
most journals are sort of like global based. It's not just like you've got journals specifically for Australia. It's pretty much like accessible everywhere.
Well, you can publish from anywhere. Yeah, the ANZ Journal of Surgery typically has an Australian focus, and is based in Australia. There's not much research which comes into it from outside of Australia and New Zealand. But yeah, they're not big multinational companies which are
Mm.
running these, and for good reason too. Like a lot of the big companies deliberately don't publish their own journals because no one will believe them. It's a real issue that they have. They want to get their research out there, but if they're publishing it in their own journal, absolutely
Mm.
you can't believe that you cannot believe that at all. You can never believe it. It needs to be free of any biases, of any what's the word I'm thinking of? Um, uh, it,
Influence or just
conflicts of interest. Yeah,
sure.
you got to have a declaration of conflicts of interest in the start of any journal. If you if your conflict of interest is we are completely financially dependent on the outcome of
Yeah.
this of this paper, you can't
Yeah.
believe it at all.
Then yeah, you're probably not doing super well
No,
with credibility in the
no,
public.
that's incredibly shot. You're always trying to get people to independently evaluate your research.
So, so on the whole, research, you're pretty happy with the state of research so far as you could tell within the realm of UWA and what you've been doing, which is pretty
Yeah,
cool to hear.
yeah.
How often do you cross contaminate? Maybe not cross contaminate, but like sort of cross over into other fields. You know, like are you ever getting involved in engineer departments and physics departments and
In my
biology?
research, a little bit. I've got some engineers involved with my PhD, and that's really interesting to cross into fields and different specialties. But not too much, to be honest. There's not a lot of crossover, and there's also just different practices of science and scientific method that you see in the other departments, which is interesting.
So once you've completed your PhD, do we just call you Doctor?
Yes, yes, yes. You have to call me.
Doctor
uh,
Crohan, please, welcome to the stage.
nah, just call me Will.
All right. So yeah, very cool to hear about the research. I did want to change up pace because we got a doctor here, so I wanted to have a quick. Again, I suppose we're somewhat running out of time, but yeah, wanted to get your sort of overall view because I'm guessing that you were still coming up as possibly resident or intern during the pandemic period. So I
Mm.
just want to know from someone inside the system as a doctor, like what was that period of time like?
That was That was wild. That was a really interesting period of time. Um, that was so the very first patient who had COVID in WA was a
Mm.
patient of mine.
Hi.
That was scary. So that was before vaccinations. That
Day
was
zero.
before
True.
we knew. That might have been the first one who died.
All right.
That was yes. I shouldn't. Not a very happy subject.
Sure.
He was. I was indirect. I was um, sort of involved with his care, and that was it was a scary time.
Mhm.
No one knew what we were dealing with. We sort of knew
Yeah.
this was coming. We were getting all these reports coming out of Italy was the one that was driving a
Mm.
lot of the scientific research in the very early stages. And I remember we had a live cross. We had a video call from one of the ICU consultants from Italy who gave a presentation to a lot of the doctors. I think it was at Royal Perth Hospital. And we left that very scared because we knew how much because they gave us a good insight into how much they were struggling and how this was not like anything they'd seen before. And then when we were looking after this patient, it was not like anything we'd seen before. The scans were bizarre, the numbers were bizarre. Um, there was a great sense of the unknown
Mm.
and um, a strong sense of anxiety about what the future held for this condition, which we weren't quite sure exactly how infective it
Yeah.
was, what
Yeah.
the consequences were,
Yeah.
what it did to
Fatal.
everyone.
Yeah.
Well, we knew it was fatal, potentially. We didn't know much else, and I think in the early days before um, good treatments were in play, and we had strong um, strong levels of vaccination. I think the mortality rate was close to 10%. It was really high, and then that doesn't include people who suffered serious morbidity, who went on to develop long COVID. people are going to forget how serious and how real COVID was in the early days. That was a hard time. It was scary for a lot of us as well. So I was I was very junior.
Mm.
I actually got forced out of my house during COVID. I was renting with a couple of non-doctors, and it was awkward. Like I'd walk into a room. They knew I'd been working at the hospital, and they'd have to walk. They walk into the. They walk out of the room. Walk
Yeah,
into.
right.
So we had to like isolate. It just was. We were in a small place. Had to move out of the house and go find somewhere else to rent because I couldn't live with them, and they were lovely, really good people, but just couldn't really put them through that. Um, so yeah, I got forced out of my rental, which was my own personal experience, which was not the worst experience people had in the pandemic.
Yeah, for sure.
It was real.
Still speaks to like the concerns everyone had at the time of just
Yeah,
what you know could this be the end of me if I was to catch it, and so
yeah,
everyone's mortality was very much front of mind.
yeah, exactly. And there were and like a lot of people died in the UK.
Mm.
The highest rate of mortality, the highest levels of mortality amongst health practitioners was amongst dentists actually early on, and then followed by ENTs. So we knew that we were really strongly at risk. A lot of the ENTs I knew, particularly ones who had their own medical conditions, type 2 diabetes, whatever, or immunosuppressed, they just stepped away from the game. One of my the bosses who I really respect, he has a child who's profoundly immunosuppressed, so he quit public practice during that time and just shut up shop. Totally fair enough.
Mm. Yeah,
He would love to have helped, but he was like, "Got to look after my family. If I bring this home, I'll kill my kid."
yeah, 100%.
It was hectic. People are going to forget how serious COVID was, and that's I think people have already forgotten. People forget like the bags of the bodies that were lining up in New York, or I think in America they've had two. What's the I think the total number of deaths due to COVID it is over 2 million now since the start of the pandemic, close to 3 million. So it's a population of 300 million. So it's 1% mortality rate from COVID in America. That's horrendous. The dead can't speak though, and
Mm.
people are going to put it down to like comorbidities. That's crap. COVID was incredibly deadly, and we've got good treatments for it now. The variants, which have now become the dominant variants for COVID, are not that bad, but it was very serious.
In the early days, yeah, it was
Mhm.
still the first time I recall thinking this is what I imagined it would be like during the Cold War, like the heat of the
Yeah,
Cold War, where
yeah,
potential nuclear war might break out, and I was like, this feels like well, this is as close as what I can imagine as what that was
yeah.
potentially feeling like at the time.
I still can't tell you how angry it is when I get makes me when like um with people peddling misinformation, like Trump getting up after he's been probably vaccinated and he's also on remdesivir and he's saluting to say, "Oh, I'm fine." You can see he's audibly like struggling for breath, and like that was one of the great moments of misinformation. That this is a bloke who's got the best class care in the world, who's got COVID, and is trying to pretend like it's all fine, and people are just sort of following in his footsteps or believing everything he says. He was sick. He was sick as a dog, and he had really good treatment.
Yeah, well, you would expect that the commander in chief
Mm,
would have everything in the kitchen
totally
sink
fine. Yeah,
thrown in
as he should
at
have.
him. Yeah,
Yeah,
yeah.
yeah.
Like I mean, from my side, I always figured I was like, do everything in your power, take everything that you think would help in that position. If
Yeah,
that's the vaccine, if that's just getting out for the daylight stuff and just
yeah,
popping extra vitamin D and
yeah,
whatever it
yeah,
else. It's
yeah.
like there was a lot of stuff coming out at the time. The only thing that I remember that annoyed me at one point was I had my GP that I was speaking with, and he was sort of going like, "Here's what I think could be helpful at the time," and
Mm.
then he was like, "But we're no longer allowed to recommend or prescribe anything that's off the uh, what's the Australian Medical Board, I guess."
It has to be
AAME?
like it has to be within on the ETG or it has to be PBS,
Possibly. It was, but he was
prescription
basically,
benefit
yeah,
services. Yeah,
it was basically to the effect of like, you can't use off-label
yeah,
stuff
yeah.
during the period where there wasn't like good treatments going on.
Mm-hmm.
And for me, I'm like, I don't mind. I never minded which direction people wanted to go and how everyone thought was the best way to go about it. But I
Mm,
do know in the early stage of anything where answers are unknown, there's always going to be, you don't want to hamstring doctors who have
mm, mm,
patients
mm.
in front of them And I don't know if this is the experience, so this is what I was
Mm.
curious about. Were you or were people not allowed to I guess experiment in some sense as a doctor, where you think I recognize some symptoms here that I
Mm.
think this might be able to help,
Mm. Mm.
and therefore like if it doesn't, you've added to the knowledge of what can and can't help possibly.
I don't think people would say, look, you can't go rogue.
Mm,
No one likes a cowboy. Um, you're allowed to treat your own patients though.
hmm
If you, as long as pretty much you can justify your own decision making, and are able to justify it in a public setting with to your peers, colleagues, and respected professionals, then yeah, it was fine. That was how they had to experiment a little bit.
mm, you have to,
It
yeah.
was it was totally unknown. They wanted to know were were reflex medications going to do damage? Could you do too many? Could you give too many steroids? Um, and did antivirals play? There was a lot of experimentation, but
Mm,
yeah, the thing with that is though that the experimentation had to be pretty transparent.
mm,
So to be able to follow those, to be able to follow a good scientific method, there is a correct way of doing things, and there's an incorrect way of doing things, and making sure that you are experimenting in a safe and ethical way
mm,
is important. If you go off label, you know, you don't want to be playing God. Um,
mm.
and there are certain,
And so you don't want to pretend there's no risks involved with doing that.
there's a lot of risk. What was the classic one they were talking? Ivermectin.
hmm
I mean, like, there's no real reason why that should have worked. There was a study that was done because the question came up, um, and it was as expected, turned out to be totally like it didn't have any effect. Um, the fact that that was raised as a question is perfectly reasonable, and but the fact that people were still touting it as a potential cure in the absence of any scientific evidence for it, um, anecdotal evidence doesn't count. You can't say, "Oh, a mate of a mate of mine had it and then got better."
Mm,
That's bullshit. That doesn't that there's no evidence behind that. That's not good reason to be introducing it as a treatment for millions of people. Whereas something like, here was the wild one, nursing people prone, basically like getting them to lie down on their tummies as they're being ventilated. Classically, horrible no. Like it's difficult to ventilate people properly if they're lying on their stomachs as
mm,
opposed to lying on their backs. They don't breathe as easily. So that was weird. However, they realized that they did that. They showed this scientific evidence. There's a paper. They were able to clear the secretions for COVID specifically much better, and they had better outcomes, a lower rate of mortality. Great example of experimentation done right and done transparently.
I'd push back only slightly on the ivermectin one because one of the guys that I believe introduced
Cortico- Yeah,
corticosteroids or
yeah,
whatever into the initial treatment plan, he sort of set the dosage at a certain rate,
yeah,
and because he I think was one of the leading cardiovascular
yeah, yeah,
docs, I think in America.
yeah, yeah.
And so then that got established into the general care plan because it significantly reduces inflammation and
That's a
and
great
bleeding.
example of that was yeah, steroids. We weren't sure if that would
Mm.
hurt or help, and that obviously helped dramatically. Yeah, yeah,
So that same doc then introduced that. He started exploring the hydrochloroquine and ivermectin and all those sort of random things that just sort of
yeah,
popped up as like, why
yeah.
would these work? And then he became a bit of an advocate for it. He said it's not a silver bullet, but so far as we can tell, the risk profile where it's been already administered billions of times, there does seem to be some evidence in some areas, particularly India and some of the basic studies.
Mm.
So
But then he
I
got
get,
proved. Yeah, I hear what you're saying. And but then he got proved wrong. Now, correct me if I'm wrong, but as I read on it, he got because it's been a while since I've read up on it, but
mhm,
there was evidence that came out to the contrary later. And the ivermectin might be because it was like they're actually treating parasitic infections, which were then contributing to someone's overall inflammatory burden. Fair, fair if that's the case, but it still wasn't an effective treatment alone for COVID.
the
And after, yeah, I don't know. Anyway,
Yeah, again, it's one of those where the only thing that annoyed me was like what I would have loved over that period of time in Australia. It doesn't have to be the whole world, but was like get a bunch of like the top docs, people that don't necessarily agree with each other, to just like kind of have these open floor
mm,
discussions a
mm,
little
mm,
bit,
mm,
just to help because it kept feeling a lot of the time that as someone that's not within the medical industry, it was hard to know, is this spokesperson for government actually speaking on behalf of
Mm,
doctors?
mm,
Like, is this really reflecting the reality of the situation?
mm.
Because if I'm talking to my GP, this doesn't seem to be his reality right now. And some of what it's, there was always just a little bit of disconnect of
Yeah.
no one knows what the answer is. That's totally fine. This is a totally novel thing. Everyone's trying to do their best.
Mm.
So let's just be open with that side of it and be like, well, we don't know. Here's our best guess at the moment. Happy to be proven wrong because we want better outcomes for everyone.
Yeah, that's very true. Like having that faith and trust in in scientific institutions is everything. As soon as you lose that, you never get it back. Hey,
Yeah,
like I think the mask stuff early on did a bit of damage. That a big
massively, and the distancing.
just the lack of. I think it was good intentions behind it, but
Yeah,
when there was lack of evidence behind it, and when even with further research, there was still a lack of evidence. That when that came out, and then you didn't immediately admit that. Oh,
maybe we got it
maybe,
wrong.
yeah, that did some harm.
And again, that's all we really. I think people are pretty reasonable if you just go, look, we thought this was the best case for X, Y, and Z reason.
Yeah,
Looks like we may have got it wrong, so
yeah,
we're updating our
yeah,
thing. We're going to get things wrong, but like we're
yeah,
really trying our best here. You'd be like, totally fair, get it.
yeah.
Same with if you're going to tell us that the vaccine is going to be 100% safe and effective at stopping transmission and whatever, you're like, okay, that's what we're hoping for. When it
Mm,
doesn't, go, oh, look, we did say that, but got it wrong. Turns out
mm,
it's not as effective as we like, but it's still great at, stopping mortality, which
yeah,
is like,
exactly.
okay, great
Yeah,
win.
I'm pro mask. Just for
Mm,
the record, I agree with it. But then there was research that came out which showed that it might not have had as great an effect as as
mm,
was appreciated. Particularly like just the basic garden variety masks he's getting from the pharmacy, nowhere near as good as the N95.
yeah.
And when they kind of like covered that up a little bit, that was a I think a bad thing for science
Mm.
to cover up to not be immediately forthcoming with the research.
That's why I think it was hard to know. Is it just will you just amplify something a little bit wrong? The media picks up something, or like one
Mm,
politician picks up something, and then it just seems like I think this is politics in general. Nobody wants to say I got something a little bit wrong.
mm.
Whilst I feel like good science is always at least coming out and being like, well, of
Good
course we're
sciences.
getting things wrong.
Yeah, yeah.
It's inevitable because we don't know everything
And you're trying to prove yourself wrong. Good science is
exactly.
trying to prove yourself wrong. Yeah, exactly. Yeah.
So it's that's always a disconnect. There are some people just working tirelessly to get answers towards things, and then you can just tell someone will be doing a bunch of research, and then like a little bit would be cherry picked, amplified, and they'd be like, "Oh my god, that's like not at all what the research is actually suggesting." As
Mm,
you said beforehand, a media might pick up a random journal article from a sort of
mm,
pay for journal,
mm.
and you're like, "Is that the thing that gets out?" Like
Yeah, yeah,
people working really hard to produce really good stuff
yeah,
and that's the one that gets picked up.
yeah, yeah, yeah.
Probably somewhat unavoidable, but cool to know. So over that period as well, did you find that there was a lot of burnout in hospital?
Yeah,
Because I mean,
massive
when I
burnout.
spoke to nurses in particular, I was like, man, you guys, this is crazy.
Mm,
The
mm,
hours everyone's putting in, and as you said before at the beginning, when everyone thought could be my life on the line,
mm, mm,
being
mm.
around this, you guys were literally at the front line of like just rocking up to work was making a stand of I'm committing
Mm.
to trying to do good with the chance of actually losing my life at this point. Like it's a pretty
Yeah, it was weird time.
substantial,
It was
yeah.
scary, but everyone was making sacrifices at that point. And at least I had a job. You know, a lot of people, a lot of my friends, like my sister lost her job. Um,
Mm,
a lot of a lot of friends and family became unemployed in that time as well. Everyone was suffering and making sacrifices, but you were in a job where you had the capacity to help and make a difference, and that's why you went in and did it. And it was, we saw the at times we saw the worst in humanity, at times we saw the best in
mm,
humanity, and you saw that um, there was also unprecedented global cooperation at that time. Um, there are a few dissenters, but people were trying to work together. We had the video call coming in from Italy. People were just trying to share as much information
mm.
as they had, um, and we had there was a lot of gratitude that the public was giving out to healthcare workers at that time. Can we pause it for a second?
Yep. And we're back. Just doctor being a doctor.
Sorry, dude.
No, all good. So I thought we'd just try and finish up on the lighter side of things, which is it's always nice to finish off on a bit of a
Yeah, why
lighter
not?
side.
Yeah, yeah, good.
So um, looking forward now, like, is there anything that you're just optimistic about in terms of medicine? I mean, again, you're an ENT, you're probably seeing a bunch of things coming out, you're researching the cochlear implants. Is there anything that you're really excited or optimistic about in the future for the
Mm.
things that you're involved in?
The, there's there's so much in medical research which is worth being optimistic about. It's increasing at a rate of knots. The one thing which I think we haven't talked about is probably immunotherapy in head and neck in
Hmm.
cancers and head and neck cancers. Sort of ties in with the guy who I think Richard Scolyer is his name, the guy who won the Australian of the Year award for his work on glioblastoma, and also he's a melanoma researcher, and his work in immunotherapy in that field has been phenomenal. I think, unfortunately, his brain tumor's just come back, but um, it's been announced in the last day or two.
Mm.
But he's still given a glimmer of hope for probably the nastiest cancer that we know about, in one which has a life expectancy of I think of a couple of months. He's lived for several years now, disease free essentially, um, and now the tumor's probably just mutated to be able to overcome the immunotherapy, which is a real shame. But it's just given us a real valuable way of treating this disease. In a similar fashion, we've actually started to come across the same thing in head and neck cancers. Um, we're more and more commonly giving immunotherapy as a neoadjuvant treatment. Immunotherapy, just for people who don't know what it is, so a little bit different to chemotherapy, which you can consider as a very blunt instrument to try
Mm.
and target certain parts of a cell's natural replication. Immunotherapy is more about harnessing or getting the body to target cancers specifically. And I couldn't go into detail. It's not my area, but it's but we know that the body's immune system does have some natural function against the development of cancer. There's all these different checkpoint inhibitors, but there's always different. Sorry, checkpoint inhibitors, what the actual immunotherapy does. There's all these different checkpoints um, in a cell's replication cycle where it stops developing into cancer, and then these get mutated, and then these undergo mutations, and it leads to a loss of inhibition for the normal cell cycle, and it starts to rapidly grow and divide.
Hmm.
Whereas immunotherapy can either help prime the body or teach the body to recognize cancer cells, and then the body itself will be attacking those cancer cells. So you're kind of harnessing the body's own natural defenses and helping it to overcome these little mutations which might be tricking the body in the first place. And what I've seen in head and neck cancer, it's all very new. This is like the last couple of years, this is like last
Yeah,
year or
well,
two. I've now operated on. There's been two patients we've had. There's been only three in total so far, last couple of months. There's now been two that I've operated on directly where they have these awful fungating cancers, nasty, horrible to look at, just like, oh, this is going to be a bad outcome. We give them immunotherapy. They get 3 cycles of it, and then they rock up for surgery, and cancer might be gone. Like
wow.
yeah, there's been two where we have found it's as defined, a complete pathological response, in that there is no longer any evidence of cancer. You see the scar tissue, you see where it was. Put it under a microscope. There's all this evidence. There's all this fibrosis, scarring that's taken place. You can see exactly where the cancer was, but the body has been able to eradicate it.
Wow.
Unbelievable. Even if that is not the case, then a number of these patients will have a partial pathological response where maybe 85% of the cancer is gone. They've still got a bit of cancer there. You can go in and cut out a much smaller lump, which is good in the head and neck because it means you're cutting out a lot less of something which was actually critical for a patient's ability to function. We can't be too specific about the details, but we
Hmm.
had a patient who their entire tongue was going to have to go, and part of their mouth and throat. They're going to have they were never going to be able to talk again. They were going to have a really horrible outcome. But we had immunotherapy in place. The tumor massively shrunk, and they were able to save most of their tongue, and
Wow.
they're going to have a pretty nice outcome. They'll have a bit of a lisp, but it's so different to what they would have had otherwise. They
Sunny
would
day.
never have been able to speak or talk or swallow again. So that's a really phenomenal change for this patient's life.
Wow. How long? Like, so you go on the immunotherapy,
Mm.
and then for what period of time?
So like 3 months. There's three cycles, typically sort of 2 or 3 weeks apart or so, and we're keeping an eye on these patients clinically, seeing them regularly, and not all of them will respond. Some of them you just need to. Some of them, okay, immunotherapy is not working. Get in, operate quickly.
Mhm.
Don't lose this. We don't want to lose the opportunity to try and cure the patient of the cancer. But others, you see, oh gosh, it's shrinking. Let's just keep giving it. Shrinking. We're still going to plan to cut it out, but yeah, this is going to be much better. Still trying to find. This is a great example of scientific method because we don't know what the optimal method is.
Mm.
There's a meeting which takes place every Monday where, and it's God, it's awful every time because
Mhm.
it's there's 40 people and there's a heated discussion consistently every Monday about what the best way to treat these patients is. And all these guys are different. These different specialists who are all across the research, who are all interpreting it
Yeah.
in the way that they think is most appropriate. They're actively sort of disagreeing about what the optimal method is, but they're getting closer. They're getting closer and closer, and patients are getting better and better outcomes. Really, really cool.
Very cool.
Really, really cool.
And cool to hear that sort of like that's exactly what I'd hope to hear in future if there is a disaster, whether it be health related or some other weird disaster. It's just get a bunch of like people that are really in the know that kind of disagree and are trying to just figure out what is going to be the best way, and let hopefully the best sort of like truth reveal itself.
Yeah, yeah. They're not good to watch these meetings because they're pretty intense. It's not, but
This is coming back to those uncomfortable meetings that you're not as much of a fan of
oh,
in the adrenaline
I
side.
hate them, but they get good out. There's good outcomes that come from it. Yeah, exactly.
Well, look, I don't want to hold up any more of your time, and I really appreciate you speaking a little bit about what's been going on with becoming a doc, ENT, some of the things that you're interested in, and I didn't unfortunately get to speak a little bit more about tonsils and how that works with a kid. There's a million things to go into, but all the same, appreciate your time, Doctor.
Pleasure. Happy to be here. Thanks, mate. Bit of fun.
Till the next time. Cheers, brother.